Hello, I'm Sophie Renton. I'm a consultant vascular surgeon at Northwick Park Hospital and the Secretary of the Vascular Society. I'd like to introduce my colleagues.
Hello, I'm Bruce Campbell. I'm a vascular surgeon in Exeter with a special interest in venous disease, and I think the reason I'm here is because for many years I chaired NICE's Interventional Procedures Advisory Committee, then their Medical Technologies Advisory Committee, so people assume that I have some insight into NICE.
Hi, I'm Manj Gohel. I'm a vascular surgeon in Cambridge University Hospitals. I'm also a member of the Charing Cross Executive Board for the Venous Programme.
So we're here at the SEC in Glasgow at the Vascular Societies annual conference, and we've been discussing venous disease with regards to what we need to do in order to develop our guidelines and to take that forward. So I'm going to start by asking you, Manj, what kind of evidence should we be thinking of for guideline purposes in the venous space?
I think what we need is high quality randomised trials to answer the key questions in venous disease. And I think one area where we have made a lot of progress and got that right is in venous ulceration. We have level 1 evidence to show that compression therapy works, so that should be delivered. Level 1 evidence to show that patients should be assessed and treated early for superficial venous reflux. And what we need is those trials to be rapidly translated into guideline documents to maximise implementation, and that's really where we need some help from NICE. So any comments, Bruce, about implementing level 1 evidence?
Well, I think in terms of implementation, NICE have an implementation team who liaise with the NHS in terms of how best to achieve these things. But once they've produced the guidance, in fact, NICE's real capacity to get out there and influence is limited, because the adoption of NICE guidelines, other than technology appraisals, which are mandatory, the clinical guidelines depend entirely on local commissioners deciding to commission services, and that is what your biggest problem.
So, which areas in particular have big gaps in evidence, and what impact could this have on guidelines in the future?
So the starkest gap in evidence is really for deep venous interventions. These are exciting interventions, and those of us involved in this space are absolutely convinced there are some patients who benefit dramatically from assessment and treatment of their deep venous disease. But we have to recognise that these are expensive interventions, they're quite invasive, and the medium and long-term evidence really isn't there. So those are the areas where we need high-quality studies. Not necessarily randomised trials, because there are real challenges with that, but certainly high-quality prospective studies.
I think one thing not to lose sight of with all these studies is the great importance of collecting, as well as the clinical outcomes, quality of life data and cost data, because clinical guidelines do depend on working out a cost-effectiveness case, which is fundamental to NICE recommending anything. And so I think that the instance of NICE clinical guideline 168 on varicose veins not being implemented as we'd wish, which is what you were asking me about, is because here are cost-effective interventions, but they are not affordable because so many millions of people have varicose veins. I think it's going to be different for deep venous disease, particularly acute iliofemoral deep vein thrombosis, for example, because that is a relatively uncommon condition. So I don't think there'll be an affordability issue if you can show cost-effectiveness.
Thinking about the deep venous system, it's going to be very difficult to do a randomised controlled trial. So how are we going to get there?
Well, firstly by collaborating, and I think the better use of registries is going to be a really important first step, and a lot of these complex heterogeneous interventions rely on registries to help us get some initial indications and ideas. And then there may be certain patient groups where we can do a randomised trial. But we really are in the infancy, particularly in the UK in this space. Yeah.
So let's take a step back and have a think about what have been the main updates in the last 5 years, or at least since the guidelines document in the venous field.
So, I mean, as well as you, Sophie, I was privileged to be part of the EVAR study group, and I think the study clearly demonstrated that early treatment of superficial reflux accelerates healing of venous ulcers. And it's a landmark study, and hopefully a study that will have international impact. And certainly for advanced venous disease, that's one of the main updates. But also the growing role of deep venous interventions. Yes, we don't have the big randomised trials. There's a small one from Brazil and Phoenix that's recently been published, but it's the increasing acceptance that there are a certain group of patients that do benefit from these interventions. Yeah.
So I've got a question, Bruce. the clinical guidelines for varicose veins, do you think we might be able to adapt those to actually engage more of the venous arena?
When you say adapt them to the venous arena,
Well, particularly for the venous leg ulcers.
Well, I think this is a really important point, because I think one of the big problems is the confusion in the minds of many people, not least commissioners and policymakers, between varicose veins, which quite wrongly they always think of as cosmetic, and venous ulcers, which are quite different, which are hugely disruptive to people's lives, hugely expensive to the health service. And so it's my view that venous ulcers presentationally ought somehow to be separated a little bit from varicose veins. Now, the ideal would be to have a clinical guideline on venous ulcer, because I think if those were to be produced in the context of the EVAR study, I think you'd have some very powerful tools. The problem is NICE had so many clinical guidelines, by memory 187 a few years ago, that it needed to keep them up to date and decided to limit the number. And so getting a new guideline subject is very difficult.
But that's what I mean. So maybe one approach would be to try and persuade NICE to set it the guidelines for varicose veins and venous leg ulcers.
Yes.
You know, and then that sort of highlights the fact that it is more than just cosmetic varicose veins.
I think if you could make that connection between this very common condition that commissioners are trying to ration and a very serious condition, then I think that would be potentially very useful.
So, thinking about the clinical guidelines, what type of data will NICE be looking for when producing, if we were to try and persuade them to update the clinical guidelines and maybe engage more with our ulcer community, as it were?
Well, I think I'm going to move slightly lateral to that question, because I think one quite important aspect of this is the reason for the current concern in the vascular community, which is some of the draft guidelines that NICE produced for aortic aneurysms, suggesting that EVAR should be used in a much more limited way. And I think it's important to draw a distinction between those, which are for a condition which doesn't affect quality of life, having an aneurysm, for which interventions are very costly, compared with varicose veins, venous ulcers, for conditions which do affect quality of life, and the interventions are relatively inexpensive. So I think there's a big difference between those two things.
And just to add to that, I think there is a perception that NICE has overemphasis on randomized controlled trials, and particularly for complex diseases such as deep venous occlusive disease, it may be very difficult to conduct a randomized trial. So I hope there's an increased consideration of non-randomized evidence, registries, prospective cohort studies going forward.
And I think the other thing, I mean, you mentioned registries, I think are important, prospective cohort studies. I mean, in terms of methodology, there are some very valid methods now for providing case control studies of high quality, for modelling and the like, which I think should be really strongly considered, as well as trying to produce randomized controlled trials. The problem in deep venous diseases, as we know, you can produce probably convincing confidence intervals, p-values and the like from relatively small numbers of patients. But the problem is when people look at the evidence, they actually want also to see some big numbers. And so alternative methodologies, I think, are really worth considering, but they have to be done very well.
Good. All right, last question is that retrospectively, what do you think the next steps should be to ensure there is robust evidence available for future guideline committees? Some of which I think we've covered.
I think so. I think it's really just to reiterate that it would be good if guideline committees could highlight the deficiencies in research, so that future researchers can really target their efforts to answer the questions that are deemed to be important by the policymakers. I think that there has been a tendency for researchers to look for areas where it's relatively easy to do research, but I think we have to tackle the difficult areas. And again, I go back to the deep venous disease. It's going to be very difficult, but it is an evidence gap. We have to try and address it. So that would be one approach.
I think NICE regards patient input as very important. And I know a lot of the studies do that, but I think the more that it can be demonstrated that study design and everything to do with studies has involved patient input and what they want, I think that's quite a powerful aspect.
Yes, well, we've been working with the Robert Lind collaboration, and I think that's probably very, very important. Okay, well, thank you very much, both of you, and thank you.